What's going on, guys, and welcome back to the world's most okayest physical therapist. I'm your host, Dr. H, and today we are doing a very quick breakdown of the difference between a doctor of osteopathic medicine and a doctor of physical therapy. And the reason why I am breaking these two things down is not to put one above the other, not to deride one and exalt the other. No, I am doing all of these podcasts on the difference between this and that, between this and physical therapy, in order to help educate everyone listening to know the different roles and responsibilities of those professions and how they can best help you when you need them. So today, like I said, we're taking a look at the difference between a doctor of osteopathic medicine and a doctor of physical therapy. Now, hopefully, at some point in the future, I'll be able to have a doctor of osteopathic medicine on this podcast, but today it's just me. So I get to be a little bit biased. But in the future, if I get an absolute smackdown by a doctor of osteopathic medicine and my friend, you will all be able to tell you that I told you so in the comments. And speaking of which, please don't forget to like, comment, subscribe, follow, rate the podcast, as it helps significantly with the algorithm. If you don't comment, if you don't like, if you don't subscribe, if you don't share, this goes out into the void and it dies a slow, quiet death. If you listen, you can almost hear it. So let's prevent that death of this podcast, and let's press on and continue educating ourselves, our friends, and our family members. So, a doctor of osteopathic medicine, what are they? They are a fully licensed physician, meaning they're very similar to an MD, except they focus a little bit more on, on more movement and joints and things like that. They do know the full body, right? So they have to be able to know, hey, this looks like acid reflux. Hey, this looks like pick any internal sort of sickness going on, strep throat versus mono versus whatever. They also get to prescribe medication, which is something that physical therapists do not do. And they also get to perform surgery. So those are already some pretty significant differences from physical therapy that if you've been listening to the podcast before, you know physical therapy does not touch. We do not touch medication and we do not touch surgery, meaning we don't perform it, but we do help rehab afterward. So physical therapy, by contrast, focuses on injury prevention, rehabilitation, pain management, and restoring long-term functional outcomes, meaning getting you back to doing what you want to do. But, and here's a little bit of a caveat already, some states allow physical therapists to have imaging performed, to order imaging. Not all, definitely not all. And even in the states, I think Maryland is one of them, for example, if a PT requests or orders imaging, that it doesn't guarantee that when your patient goes there, they will have imaging performed. Sometimes they'll go to the x-ray place and they'll be like, no, we don't recognize this. We don't think physical therapy can do that. So even in the case of states where you're allowed to as a physical therapist, sometimes functionally it just doesn't happen. The only exception to a lot of the things that I'm saying are going to be, we're excluding any physical therapist working in the federal system. Any physical therapist that works for the federal government is special, and they get different abilities, kind of like a superhero, than normal physical therapists do. A physical therapist in a federal setting can definitely order imaging, but in the state side, cannot. State side or the private sector cannot. So let's talk about education, because that's one thing that really sets physical therapy and doctors of osteopathic medicine apart right from the get-go. And once you see these numbers, or you hear these numbers, you'll understand why. A doctor of physical therapy on average spends about 7 years total in school, 7.5 in some cases, 4 years undergrad, 3 years at graduate level. And that's not including any sort of residency that the physical therapist might do afterward, but 7 years is a pretty good number there. A doctor of osteopathic medicine is spending 8 to 12 years in total, and they require a residency, which is at least usually another year. My friend, for example, who's a doctor of osteopathic medicine, went and did emergency medicine, which he is still doing. So right out the gate, you can see 7 years versus 8 to 12. And again, like I was talking about earlier, physical therapy, we're focused on rehab. in your musculoskeletal system and your neurological system, and of course your vestibular system. Meaning, I'm focused on your nerves, I'm focused on your muscles, and I'm focused on your inner ear and the things ascribed to your inner ear that help you balance. But a doctor of osteopathic medicine is going to know your entire body and is going to be able to help you when you have strep throat, acid reflux, autoimmune diseases, whatever. That's their lane. Their lane is to help you with internal medicine and external medicine in that case, right? I guess you call it external medicine, meaning like the musculoskeletal system, versus PT, where we are really focusing on the musculoskeletal system, the neurological system. And that doesn't mean that those two worlds don't ever interlap, right? So if you have a patient that has an autoimmune disease as a physical therapist, like lupus, or pick any of those debilitating diseases that you want, ALS, multiple sclerosis, anything like that, physical therapy is still going to be able to help in those cases, but we're not going to be prescribing medication. We're going to be prescribing exercise and trying to modify the environment in order to help the patient with that condition have functionality as long as possible. But you can see the difference. The PT is going to be there in the mix of it, doing things about it in a physical sense. A DO is going to be giving you medication and trying to chart your entire your entire plan of care. So they're going to be prescribing you medication while also prescribing you physical therapy, while also possibly trying to get you additional tools and services in order to help you. PT is only going to be focused on their lane of physical exercise and interventions like that. And the residencies are interesting. I think physical therapy only has three main ones. One is neurological, one is osteo, ortho-based, and the third one I want to think is sports-focused. But basically that means it's a residency you're going on for another year, and you're either further getting education on neurological, joint and bone and muscle, or sports. And that sort of residency kind of defines you as, are you the neurological expert in your clinic? Are you the joint and muscle guy and sports-focused? Or are you just a normal physical therapist that may have additional certifications and trainings, but you didn't go into a residency program like that? Scope of practice. Like I talked about, PTs cannot diagnose. This is huge, and this is, if they're getting one thing to take away from this entire podcast, we as physical therapists cannot diagnose you with anything. If you walk in and your ankle is barely hanging on by a thread, I cannot tell you that you have torn every ligament in your ankle. I can tell you that the signs and the symptoms that you are presenting with are consistent with the tearing of the ATTL, ATFL, and CF ligaments and the Achilles tendon. But I cannot tell you that you have definitively torn them. Okay, I'm not supposed to do that. My job is not to diagnose. My job is to screen you and then say, yep, you need to go and talk to your doctor because it looks like every single ligament in your ankle has been torn. And that would be where I would either refer you to emergency medicine and say, you need to go to the emergency room right now. Or I could say, hey, it looks like you maybe really strained one ligament. You should go and talk to your doctor, tell them that PT saw this, and you should probably get some MRIs or x-rays performed. Remember that x-rays don't actually help you with seeing any ligaments, tendons, or muscles. It helps you see bones. MRIs help you see what we call the soft tissues. But typically when you go to your doctor, they're going to want to do an x-ray no matter what, and then they're going to want to follow up with an MRI. But that's how the PT fits into this picture. We do not diagnose. We simply say, this looks like this, and then we tell you to go and talk to your doctor, or we email or call your doctor and say, yeah, it looks like, Johnny over here really did a number on his ankle, and he probably needs surgery. What we do get to do is we do get to treat. We do get to, once we're told what to do, or when the patient comes in and says, hey, I'm having shoulder pain, and we evaluate on our own and say, it looks like this, and this is how I'm going to treat it. This is why you hear physical therapists all the time say that we treat impairments. We don't treat conditions. Because if you come in and you have weak shoulder strength in several different directions and really tight muscles in several locations, I'm going to go in there and stretch them, and then I'm going to strengthen them. And then I'm going to see if that improves your function. And if it does, boom, we solve the problem. You're back to doing what you want to do. If it doesn't, that's when it's all right. it's probably time for you to go and talk to your doctor because something else might be going on here. We've been giving this the good old try for 8 weeks and you aren't getting any better. So that's physical therapy. Doctors of osteopathic medicine, they will diagnose. And the way that this usually works is if you go to your doctor of osteopathic medicine first and you say my shoulder hurts, and they run an entire test and they come back and say it's shoulder impingement, they write you a referral for physical therapy. And then me sitting in my clinic, I get a notification that I'm evaluating a patient in a week or two that is coming in for shoulder impingement, and the direction from the doctor of osteopathic medicine to me is to evaluate and to treat in order to help the patient get back to doing what they want to do. Doctors of osteopathic medicine, like I said, they can also prescribe medication. PTs cannot. So every single time you say, hey, should I be taking the medication my doctor gave me? A PT is required to say, yes, you should be following the guidance of your doctor. Now, they might be saying that sounds like it's a little bit too much. Let me email your doctor and say, hey, is this really the dosage that you want them to be taking? Because it seems a bit excessive for their body weight, for example, or whatever. Also, order imaging and tests. I think we covered that. And surgery. Surgery. Doctors of osteopathic medicine get to do surgery. PTs, of course, do not. And where you'll find them very quickly, like I said, PTs, you find them all over the place: outpatient clinics, hospitals, telehealth, home health, skilled nursing facilities. If it's a physical therapist that is also an athletic trainer, like we talked about last time, you can find them in schools and sports teams. Doctors of osteopathic medicine are going to be hospitals, private practice, urgent care, emergency care, family med, and surgery centers. And the really good quote on this is, you'll probably see a physical therapist more than you'll see a DO, because the doctor of osteopathic medicine will probably only see you for 12 to 15 minutes per appointment. Well, if you're working with a PT in a private setting, you're probably going to see that physical therapist every single time. At the very least, you're going to see the physical therapist for an evaluation and a reevaluation and probably a few sessions in between. But in a one-on-one focused physical therapy private clinic, you're going to see the physical therapist every day that you go in there. And that helps the physical therapist keep a pulse on you and to see how things change. But part of the way that works is it's the physical therapist's job to note any significant change or degradation or loss of function or decline. So that way they can go to the doctor and say, hey, I'm seeing this, things are changing. This patient needs to be seen again for changes. Something else is going on besides just a strength deficit or neurological involvement. So why do they get confused? Well, both have doctors in their name, right? So that's confusing for a lot of people. And that's where I wanted to hit on this. When you tell a PT, hey, should I be taking my medication? The physical therapists were not allowed. Our discipline of physical therapy, we're not allowed to tell you to stop taking medication. It's not our job. Just like we're not allowed to order imaging by and large, it's not our job. It's not our realm. It's not our specialty. Legally, we are boxed out of that. We are not allowed to touch it. We don't go to school for it, not to prescribe medicine, and we don't go to school to prescribe imaging. We go to school in order to get better at helping you move and return to what you want to do. And we do that by studying the neurological system and the musculoskeletal system and the vestibular system. And of course, the cardiovascular system a little bit as well. I keep leaving that one out, but that's what we do. The doctor of osteopathic medicine is the one that is the discipline that is focused on prescribing medicine and prescribing imaging and interpreting that imaging. A physical therapist cannot take a look at your x-rays and MRIs and tell you what you have. We can tell you what it looks like. We can tell you from our experience what it looks like. We can't tell you definitively what you have. That falls to either the radiologist or the doctor of osteopathic medicine. Now, the big question, can DOs and PTs work together? Yes, and when they do work together and they have open lines of communication and both understand their roles, which is not hard. That's not like, I'm not saying DOs think they're PTs and PTs think they're DOs, but when both know each other and respect each other and know where their disciplines are and where their strengths are, of course, that's going to help the patient, you, have the best outcomes ever. The doctor of osteopathic medicine is going to bring his or her entire knowledge of what could be going on with your body from, again, the inside out, and the PT is going to be looking from the outside. And so if there's something that the doctor of osteopathic medicine maybe overlooked because they either don't know a special test because they don't go as in depth in it as we do in PT school, or your symptoms change over time and it looks like you're starting to have other issues, that's where the PT strength shines. Because we get to see you usually every eval and every re-eval and a lot of treatments in between, we have a better pulse of how you're changing and how you're progressing versus a DO who maybe just reads the notes but isn't getting to watch you change in front of them in real time. So that's a little bit of an edge that goes to the PT, in my opinion. Not that DOs aren't synergistic as much in that relationship, but it's more the PT is putting in the work day to day and sending letters to the DO saying, here's how much better the patient is getting, this is working, or hey, the patient is not getting better, this is not working. And that, again, that communication, that open line of communication helps the DO respond faster and say, all right, I'm pulling the patient back in, something else is going on, let's get this, let's nip this in the bud while we can. Let's try and solve whatever this is as fast as humanly possible. Versus, like, let's say, a PT who was trying to take over the role of a DO and say, hey, you definitely have this diagnosis. You have all these things, blah, 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 blah. That is a PT overstepping their bounds, and they should not be doing so. The PT should always be saying, hey, I think this is this, but you should go talk to your doctor. And hopefully what ends up not happening is what I'll cover here in a second, that the DO and the PT get into a disagreement, but even that doesn't necessarily lead to anything bad. It a lot of times can lead to something better for the patient. So let's talk about a real world example real quick, and then we'll be done because I know I'm going a little bit long. Thank you for hanging in there with me. So real world example is John, who comes into the doctor's office, the DO's office, and says, hey, my left shoulder has been hurting for the last 2 months. I've been trying everything and it just won't go away. Well, while he's going from the waiting room to see the doctor of osteopathic medicine, we know that he's going to be seen by a nurse who's going to take his blood pressure and his height and his weight, and maybe he's told, hey, you know, John, your blood pressure is still kind of high. Have you been taking your blood pressure medication? No, you haven't. Oh, okay. Well, maybe you should be doing that. Again, that's going to go down between the doctor and the nurse and the patient. The doctor is going to come in and see him and say, you should be taking your medication. That's also the same if John came to the physical therapy clinic and said, you know, I feel kind of lightheaded. And then the PT took the blood pressure and said, this is kind of high. Do you have blood pressure medication? And the patient said, yes, I do have medication, but I'm not taking it. Guess what the PT is going to say? You should be taking your medication as prescribed. But here's the difference. John, let's say his blood pressure is actually low, and he's been taking his blood pressure medication. Well, the nurse is going to say, interesting, I'm going to make a note for this for you to talk to your doctor. Also, it seems like your weight's kind of come down. Good job. And John says, yeah, I've really been exercising a lot and running a lot and been taking a really big focus on my health and nutrition. And the nurse goes, great job, John. It looks like you've lost X amount of pounds from the last time we saw you, and your blood pressure is down. I'll be sure to tell Dr. So-and-so about your progress. And then he goes into the room and he sits down and he's massaging his shoulder, his left shoulder, because it hurts. And then about 5 minutes later, the doctor of osteopathic medicine walks in and says, John, so good to see you. Wow, look at you. You've lost X number of pounds and your blood pressure is down. Wow, quite a bit actually. You're a little bit low. Have you been taking your blood pressure medication? You have? You know what? Let's stop taking that blood pressure medication, John. It looks like you don't need it anymore. And John goes, wow, really? And the doctor says, yes, stop taking it. Anyway, let's take a look at your shoulder. I want you to hold it here. I want you to move it like this. Wow, yeah, okay, interesting, yeah. It looks like you have shoulder impingement, John. You said this has been going on for about 2 months? Yeah, it looks like it's been going on for 2 months. Okay. Well, here's what we're going to do, John. We're going to cover a couple bases here. We're going to take an x-ray. Just make sure nothing else is going on at the bones, maybe some arthritis or something, because John, you are getting a little bit older and arthritis does start to set in. And then maybe we'll take an MRI because, maybe it looks like something's going on in your muscles. I'm not 100% certain, but I'd rather just, cross that off my hypothesis list instead of letting it linger around in the background. But I'm writing you a prescription to go to physical therapy down here to the road to Dr. H. And Dr. H is going to see you. Okay, John? All right, John, it's good seeing you. Good job. Keep up the work, buddy. Don't forget to drink water. See you later, buddy. Bye. 2 weeks goes by. John comes into the physical therapy clinic, and he walks in, sits down, does all his paperwork, gets called into Dr. H's office, and Dr. H says, hey, Hey, John, nice to see you. I see here you stopped taking your blood pressure medication. And John goes, yeah, I did. My doctor of osteopathic medicine said that I should stop taking because I was low last time. And I go, okay. You mind if I take your blood pressure, John? John goes, no, go ahead, take it. And I take it, and it turns out it's high. It's actually pretty high. It's like 140 over, let's say, 89. I go, oof, John, that's kind of high. I'm going to write a note to your doctor here. You should probably go back and talk to him that, here about 2 weeks later, your blood pressure is back up, and that's kind of high, actually. Maybe you should go talk to your doctor. And John goes, yeah. I just get I get white lab coat syndrome. I get really anxious around people around here, to see doctors, new settings, get anxious. I go, that's okay, John. You should still talk to your doctor over there about that, because this is a sign that you should probably be back on that medication. Maybe it was just too high of a dose for you, so we need a little bit less. But again, that's not my job. But you should talk to your doctor. Pause. John's already frustrated. He just got told that he was doing great. He just got told that he doesn't have to take his blood pressure medication anymore. And now he has a different doctor tell him that he should be on it. That's frustrating. But that is the PT sticking to their realm. They notice that the blood pressure is high. They know that the patient was taking blood pressure medication before, and now they haven't. It's their duty to respond to the patient and the doctor and say, hey, his blood pressure is high. Do you want to have him go back on blood pressure medication? Right? So we're already doing the right thing, but you can already see how to a patient coming into this situation, they're confused. They were just told by one doctor to stop, and they're being told by another doctor, maybe you should go back on it. And they are not going to inherently know that the doctor of osteopathic medicine is the only one that can tell them to take their medication and prescribe it to them. And a PT cannot. Right? The PT cannot tell them take this brand new medication. Okay, so that right there is what I'm harping on, part one. All right, resume. John says, anyway, I'm here for my left shoulder. Can we talk about my left shoulder? That's actually more important to me today. The physical therapist says, absolutely, John, go on. And John lists all these things, and he brings his MRI result and he brings his X-ray result. And Dr. H says, hey, did anybody actually go over your results with you? No, not yet, John says. I haven't been able to go over it yet because my doctor hasn't been able to call me yet. But here, you can take a look at these pictures, right, and tell me what I have. Dr. H says, I can't do that, John. I can take a look at these, and it looks like maybe there's some stuff going on here, but I can't tell you from these pictures in this video exactly what you have. Do you have anything that says like the impression or the email from the radiologist that took this? And John says, nope, all I got is the videos and the pictures. And then Dr. H goes, great. I can't tell you that you have this, but I can tell you that it looks like it's a little bit of arthritis. That's what it looks like. I can't tell you definitively that you have it, but this looks like what I've seen before, which looks like maybe a little bit of arthritis, because everybody over the age of 30 has a little bit of arthritis somewhere. And we're just going to have to wait till your doctor tells you exactly what it is. But anyway, let's go on and do some special tests, okay? And then Dr. H does a lot of the same tests that the doctor of osteopathic medicine did, and comes to the conclusion that not only does John probably have shoulder impingement, he might also have some sort of strain of one specific muscle in his rotator cuff. Well, now John's perplexed. One, he's frustrated because the PT brought up the possibility that he has arthritis, not just impingement, and he also probably has some sort of rotator cuff issue going on. So now John is dealing with 3 problems instead of 1 problem, and he's starting to wonder why the doctor of osteopathic medicine didn't also tell him that he might also have arthritis. And how did this doctor of osteopathic medicine miss a possible muscle strain? That's not how the system is designed to work, but it's also what happens a lot of the times in the clinic, is if you as a PT see things and you call them out, well, sometimes it frustrates the patients more and they lose faith in the DO, and that's not what should happen. The DO is doing their job. They just haven't been able to call the patient yet, because here's usually what happens. A couple days go by, the doctor calls and tells John that he has arthritis in that left shoulder, because everybody over the age of 30 has arthritis somewhere. And he also has a little bit of a strain and swelling of a specific rotator cuff muscle, the same rotator cuff muscle that the physical therapist found. It just happens to be that the physical therapist, who spent an hour with the patient instead of 15 minutes, because that just seems to be how things break down in the medical system, was able to more thoroughly screen the entire shoulder using all the special tests and strength assessments that the PT had in his inventory, to better evaluate what was going on with that specific shoulder on that specific patient. And that, in that instance, the PT happened to be right. It's just as easy if the physical therapist thinks there's a strain going on of a specific muscle and all of this imaging comes back and it turns out it's just a little bit of arthritis and likely shoulder impingement. But you can see very quickly just from that example how John can get very frustrated at the medical system and feel like no one's helping him and everybody's giving him conflicting answers. And the truth is, from the 10,000-foot view, from the 100,000-foot view, John is actually getting the best care. The DO did exactly what he or she was supposed to do and called him with the results. It was just a day or two after he had the physical therapy evaluation. And the physical therapist did exactly what Dr. H was supposed to do. He thoroughly evaluated that entire shoulder from soup to nuts, found extra things that the DO maybe didn't initially think was going on as severely as it was, but it was. And it turns out John's still going to get the best care. And if John gets back on his blood pressure medication, but at a lower dose, now he's actually doing way better than he was before he set foot in the PT clinic. And that is how the DO and the PT system synergizes. But you can see now how it's not always a perfect system. And it's not always super smooth because life happens. And when life happens in between point A and point B, between me and the DO and the PT, things can change and it just seems ever more complex, ever more frustrating, and ever more confusing to people if they don't understand the difference between the two and that they are talking, the DO and the PT, and that they are both trying to provide the best care. And even if the doctor of osteopathic medicine thinks it's only shoulder impingement and not rotator cuff impairment, and the PT thinks that's both, guess what? The PT is going to treat both and try and get John back to doing what he needs to do. And that's where inherently a little bit of decentralization in the medical healthcare system is good because it allows the different disciplines to really shine and to do what they're meant to do. One can prescribe medication and go after internal issues in internal medicine, while the other discipline gets to focus on the musculoskeletal system, which is their responsibility, and both get to work together to improve John's life. And that's the big takeaway, that when open channels of communication exist between all of your healthcare providers, no matter who they are, and they excel in their disciplines and they aren't interested in trying to play each other's roles, which doesn't usually happen, you as a patient get the best care. And it may seem confusing and it may seem conflictory, but it turns out that they are all working together, and sometimes they're communicating the same thing or they suspect the same thing, but they just don't get to say that you have it until the other one confirms it. And sometimes, even when they disagree, it's not going to be a net negative. It actually means that they're going to help you solve a problem because they found different ways to approach different impairments that both of them get to excel at. So, this has been the longest episode that I've done this podcast, and I apologize, but it is the difference between a doctor of osteopathic medicine and a doctor of physical therapy. Thank you guys so much for watching. Please don't forget to like, comment, subscribe, follow, and rate the podcast, as it helps immensely with the algorithm. And please don't forget to share it. I know this was long-winded, but the more people get to know these things, the better they can navigate the American healthcare system and the better care that they can get and that you can get. So, everybody stay healthy, stay fit, and stay awesome. And I will catch you all in the next video.